So, hello everyone. This is the part second of my hip examination. So, I'm going to start from the gate itself. So, I think I have had discussed about the inspection, but uh, I didn't discuss gate in details. So, gate is very important. First of all, gate. You have to say about gate. So, gate. Types of gate are one one type of gate is a Entalsi gate, other is a short limb gate, other is a Trendelberg gate. These are three are important: Entalsi, short limb, and Trendelberg. Other than your Wadling gate, your Intuing gate, and those are also there. So first of all, if it is the your Entalsi gate, how patient will walk in the Entalsi gate. So patient will walk the shoulder droop on the opposite side like this. Opposite side. So for example, this side hip is affecting. So patient will walk like this. Shoulder will drop in the opposite side. That is antalgic gait. Then what is short limb gait? Short limb gait is where so this suppose this is hip is affected. So shoulder will droop in the same side. So that is short limb gait. That is short limb gait. Then what is your Trendelberg gait? Trendelberg gait is when you stand in the affected side, then your normally your SIs go up, but what is your this is hip is affected, your SIs drop down. So to compensate this, there will be a lurch. A lurch will be developed like this. Like this, a lurch will develop because to compensate that drop in the ASIs down. Other than waddling it with the bilateral lunge, then that is waddling it, duck walk, waddling it, bilateral lunge. Okay, then comes to the other part of exam, that is palpation. Inspection, I think I already discussed. So palpation, in palpation, first of all, we have to know that where is the how to know where is the ASIs. So mm, go from midline from pubic symphysis along the inguinal ligament. From midline to the inguinal ligament, go along the inguinal ligament from the midline. So you palpate that first bony prominence from there. That is your ASIs. How to palpate GTs? GTs come along the shaft of the femur. Then first bony prominence you feel, that is GT. And on gluteal bulk you feel bony prominence, that is your ischial velocity. So feel tenderness on these 3 points. Okay. Then where is the anterior joint line? The examiner may ask where is the anterior joint line. Anterior joint line, it is midway between the pubic symphysis and ASIs, midpoint is there. Okay, midungual point. So below 1 centimeter below and lateral, that is your anterior joint line. Okay, below the midungual point, 1 centimeter below and lateral to the midungual point, that is your anterior joint line. Okay, anterior joint line. This is okay. That is your anterior joint line. Posterior joint line, nothing but from your PSIs line down to the SIs and medial 2/3 to lateral 1/3 point there. That is your posterior joint line. And so all these things you have to know about the palpation and Of course, you have to tell in palpation that is a common thing, temperature, rise temperature, tenderness or tenderness, or I already talked about. Then, other than that, some one I already talked that in the previous video, that is a vascular sign of Bharat. Vascular sign in Bharat is nothing but the palpation of the femoral pulse in the your femoral triangle or your Scarpa's triangle. If it is absent fever, that is positive. Can't say absent, but you can say it is not palpable. Then it's fever, positive sign. Maybe occur in the dislocated hip. Okay. Then other than that, your one is your brand triangle. That is very important. Branch triangle is nothing but that is your thumb on the GT, your thumb on the GT, like GT, and your sorry your sorry your thumb on the ASIS, and other your index finger on the GT, and that your middle finger parallel to that is how to make your branch triangle. Okay, thumb on the ASIS, your index finger on the GT, and to parallel that one line is that is your make your brand triangle. Okay, thumb on ASIS, index finger on GT. So other fingers parallel to that, middle fingers parallel to that. That makes your brand triangle. Brand triangle, to know that there is any supratruncal pathology or not. To know that, we have to know about branch triangle. Okay. Uh, if it is bilateral supratruncal pathology, then what we have to do? Then we have to know about uh, Nilatal line. Nilatal lines tell you about bilateral pathology. Nilatal line nothing but is from the ischial tuberosity to ASIS, line drawn from the ischial tuberosity to the ASIS. Line drawn from the ischial tuberosity to ASIS. That is Nilatal lines. So if it is cut to GT, that is abnormal. If it is just touching or go above, that is not okay, normal. But is cut the GT, that is abnormal. Okay, means there is some pathology there. It is cut to GT, Nilatal line. Other than that, say one is the Shoemaker's line. Shoemaker's line, nothing but it is a line drawn from the GT to the sorry ASI's GT to ASI's to the umbilicus. So if it is go touch to umbilicus or above the umbilicus, then it's normal. If it is below the umbilicus or it is not cutting both lines, not cutting the midline, that's abnormal. Okay. If it is both lines from the your ASIs from your GT ASIs and to the umbilicus, they are not cutting in midline. That also abnormal. Which they are cutting the below the umbilicus, below the level of umbilicus, that also abnormal. So that also showing that some pathology there, your migration of GT above or whatever. Okay, one side. Then other than that, Shoemaker's lines, Morris bite trochanteric test is there. Two lines drawn from the line drawn from G to the pubic symbiosis. So one lines, suppose the one line is A, other is B. So or one line is shorter than other, that is abnormal. Okay. Maybe again it's a proximal migration of GT that maybe cause about that. So now we going to talk about all about our your deformities. Means your coronal plane and sagittal plane deformity. Like sagittal plane deformity is your flexion and extension deformity. Okay, in sagittal plane. This is the sagittal plane. So sagittal plane deformity is your flexion or extension, or your coronal plane deformity. Coronal plane deformity, that is your abduction or adduction. Abduction or adduction deformity. Okay, that is we have to know. The what is the flexion deformity? In flexion deformity is one important test, that is your Thomas flexion hip flexion test. Thomas hip flexion test. How we have to do Thomas hip flexion test? Ask the patient to lie down and then flex your unaffected hip, or then hold that side. Then see the other side, that how the deformity comes, and whether you see how you have to see the whether it is your mm, lumbar lordosis is obliterated or not. That you have to confirm that. Then see the how much there is a deformity. So that is not fixed flexion. You have to passively extend that knee. Then that is the fixed flexion deformity. After you passively flex that affected knee, that is a fixed flexion deformity. If it is fixed flexion deformity is bilateral, then how you know it's a bilateral? Then you have to do your Stelli's test, Stelli's prone test. Then you have to patient lie on the prone and keep the your palm flat on the back, lower back, just above the buttocks, lower back. Then ask the patient as you extend that. If it is your moving your hand or fingers, then it's positive. Otherwise, it's negative. That is your Stelli's prone test, bilateral path, fixed place and deformities. That is Stelli's prone test. Other than that, extension deformity that not that common, so I'm not going to talk about that. And other than that, your abduction deformity. In abduction deformity, what happens? If it is your abduction, patient is abducting, but patient abduction deformity. Patient has abduction deformity, so patient cannot walk like that. Okay, so he have to bring that leg inside. So it will be your ASIs will drop down. Bring inside his leg. So ASIs will drop down. Okay, there will be apparent lengthening will be there. ASIs will drop down. Apparent lengthening will be there, and so there will be true shortening more than the apparent shortening. Okay, true shortening more than the apparent shortening in the abduction deformity. So this is opposite to this adduction deformity. Opposite to this. So okay. So here is this. There is ASI is fall down in the adduction deformity. It is come up. Okay, or true apparent shortening and more than the true shortening in the adduction deformity. Okay, so and just opposite both are. Then comes to rotational deformity. The rotational deformity is not. We have to know nothing but in rotational deformity, one just to see if it is you have a external rotation deformity. If your leg is external rotated, then you have to further external rotate that and see how much there external. If it external rotated, then you have to internally rotate that. Okay, slightly passively internally rotate. You have the external rotation deformity of leg, then you have to passively internal rotation, then you measure that angle. That is your rotational deformity. In rotational deformity, one test is comes your, that is your sectoral sign, very important. That is seen in the avian. Okay, sectoral sign nothing but in extension there is a no restriction of the your external rotation, but you have to see if you flex the your hip, then then you extend rotate hip, that is restricted in the flexion. Okay, in flexion there will be restriction of the external rotation in the sectoral sign. So, what is the sectoral sign? Sectoral sign nothing but your hip. Rotation is restricted in the flexion position. Okay, extension is no. So that is the sacral side. Then comes to the other point of the examinations, we can talk about your Alice test. Alice sign is nothing but Alice test or Alice sign is nothing but that is your flex the both the knees and keep parallel to both the knees and ask the patient to uh, okay, then see that there is a shortening of the both the tibia or femur can be seen like this. This is the knee. Suppose this is the knee, this is the parallel. Then if it is shortening, then you have to assess that if it is tibia shortening or femur shortening. From the femur, for tibia shortening, we have to see from femur side. For tibia shortening, we have to see the femur side, and for femur shortening, we have to see from the tibia side. Okay, so that is your Ellis sign. Then all about movements, and movements is nothing but your flexion is roughly around if is your active flexions around 100 degree, which is passively is possible about 120 to 130 degree flexions. Then extensions roughly around 30 to 45 degrees, and then comes to abduction and adduction. Abduction, of course, around 20 to 30 degree, and of course, your adduction around 15 to 30 degree. So, all these are there. Then comes to the your measurement. Measurement is we have to do in two ways. One is your apparent measurement, one is your true measurement. Apparent measurement from the GP sternum to the tip of the medial malleus, tip or crest, whatever you say, from the GP sternum to tip of the medial malleus. Okay. Then your for that you have to prerequisite is that both the limbs should be parallel to each other, and both limb in the midline. Okay, midline and parallel to each other limbs should be. Then comes to the true length measurement. True length measurement, for the true length measurement, the main prerequisite is the your uh, pelvis should be square. Squaring of pelvis. What is the squaring pelvis? Squaring pelvis nothing but your if it is meet one line to the one ASI to the other. One line is drawn to the one ASI to the other ASIs. Okay, then one line drawn to midline. It is cut that on the 90 degree. That is the squaring of pelvis. Okay, then one test is the Kothari's method. Kothari's method. What is Kothari's method? Kothari's method is that if you like in the abduction deformities, your SIs will be hold down. So you have to draw the line one SIs from the other SIs like this, and other line from the these two SIs. The angle made between that is the Kothari's angle. So like this you have to tell all this. Then other than that, signage line is there. Signage line is nothing but line drawn from the one SIs to the other SIs, and one GT to other SI. That should be parallel to each other. These two lines. Okay. So these are the main thing in the hip examinations. All about I know. So yeah, these are the main thing. There are also many things there, but I'm not going to talk that here. So that's all about today. So goodbye.